This time on the latest procedure. Peripheral artery disease, or PAD, is a condition that affects nearly 18 million people in the United States. Most commonly found in the arteries of the leg, the disease is often a precursor to heart attack and stroke. However, when left untreated, PAD has dire consequences all on its own.
Failure to recognize or be aware of the symptoms is likely the most common reason why it's underdiagnosed.
Every year in the U.S., nearly 180,000 amputations are performed because of a severe form of PAD called critical limb ischemia. Tragically, many of these amputations could have been avoided.
If I had gone in sooner and hadn't ignored it as long as I did, I'd still have my big toe.
Today, there are new options utilizing endovascular technologies like balloons, stents, and atherectomy devices. The procedures restore blood flow, salvage limbs, and save lives.
So this is what you can see, guys.
In today's world of emerging medicine, an amputation should only be a last resort.
The latest procedure, endovascular leg therapies, is made possible by contributions from the Friends of 8, members of 8 Arizona PBS who give additional gifts to support original programs.
I'm standing here just outside a specialized operating room called an endovascular suite, where in just a few minutes we'll witness firsthand a procedure that will hopefully restore blood flow to a patient suffering from peripheral artery disease. A procedure where high-tech medical imaging and catheter-based tools replace long incisions and scalpels. Peripheral artery disease affects nearly 18 million Americans, and it's growing. For those who let the disease go untreated, 30% pass away within 5 years. Even for those fortunate enough, yes, I said fortunate enough, to survive and receive a limb amputation, their life expectancy drops by a staggering 50%. 50%. Unimaginable figures for an invasive decision that many times could have or should have been avoided. It's estimated that nearly 49% of amputees never even receive a proper screening for PAD, and many remain unaware there are options other than an amputation. Today, we're going to learn more about PAD and alternative treatments to restore blood flow, so that you can make an educated decision about what is best for you or someone you love when facing this life-altering decision.
My name is Donna. I have 2 grown children. I have 7 grandchildren. And I can't tell you how long I was having problems with it, but it was discovered last year. This foot, I guess I would say the toe area, it was starting to hurt, and as I ignored it, it got worse and worse to the point where it hurt to put shoes on, hurt to walk. So I wasn't one of these people that really liked going to the doctor, but I did eventually make an appointment. You know, I can't get up and run 2 miles. I couldn't make it. I'd have to stop 10 times in between. And when you start to live with that, you kind of get used to the stop and go, and you don't realize when it's becoming a little bit worse, you know. I didn't put two and two together, but I exercise every day on my treadmill, and it's like I was usually doing 30 minutes, and then I was doing 15 or 20, and I was tired. Well, I was doing 15 or 20 because the circulation was starting to get blocked.
A wondrous network of arteries carries oxygen-rich blood from the heart to all areas of the human body. When disease strikes within these arteries, they begin accumulating plaque or atherosclerosis. These areas usually continue to narrow until they obstruct normal blood flow, starving the downstream tissue of vital oxygen. The condition 59-year-old Donna Riesco was experiencing is peripheral artery disease, or PAD. PAD is any arterial disease that lies outside the heart. Common locations for PAD are the carotid arteries in the neck, arteries within the abdomen, and arteries that supply blood to the legs. It is in this area that many people experience their first symptoms of arterial disease: leg pain, fatigue, ulcers. Remarkably, countless patients go undiagnosed, while many others are treated way too aggressively. In Tucson, Arizona, doctors John Pakanowski, Luis Leon, and Miguel Montero Baker are working to solve this dilemma. They are helping pioneer new therapies and are determined to educate the world about the pitfalls of PAD.
So, if you see your PCP, your primary care physician, and you are diagnosed with PAD, are there like different stages or categories of risk or severity?
Absolutely. And that's where trying to identify those patients before it gets to a severe point is crucial to try to do something and intervene in the best possible way. PAD, there's multiple classifications out there. We can say from a mild to a moderate and to a severe stage of peripheral arterial disease. When I say mild, he's doing his holes. He has to stop every so often because he can't finish his 18 holes as he did 5 years ago. He has recurrent pain that doesn't allow him to walk certain distances. That's when it starts mild. Then you have the person that unfortunately comes maybe in a nursing facility and cannot even sleep at nights because they have so much pain in their legs. So now we're into rest pain. And then unfortunately, if somebody allows that to progress, and many times that's the subgroup of our diabetic patients, then they come with gangrene, meaning their toes or any part of their foot starts developing ulcers and necrosis. Necrosis being the word we use in medicine to say dead tissue. And you would say, well, why would somebody wait till their tissue's dead? Well, unfortunately, diabetics have neuropathic issues, which means that they can't feel. And so I had one patient once come to me, had a glass stuck to his toe that he stepped on for 2 weeks, and he didn't even notice this was going on. And of course, when he got to our office, he had a lot of infection and gangrene, and he was immediately a severe PAD in a patient that was 2 weeks ago asymptomatic and going on with his normal life.
The most severe stage of PAD is called critical limb ischemia, and one such patient is 82-year-old John Lowry. John has neuropathy in his feet, and while vacationing in Mexico just days before, discovered an ulcer on the bottom of his right foot.
Well, I was on a nice vacation down in Cabo, and Sunday, as I started getting in the pool, saw a little blood coming in the water, so I jumped out. And at that time, I just thought I had a blister, and my son put some Band-Aids on it, and I thought I was fine. That evening, I started to get the swelling, and I had a fever that night. So we thought we were going to have to do something. The bad news is, I didn't realize that I had a wound because I have neuropathy. But the good news is, now it doesn't hurt because I got neuropathy.
PAD, is it susceptible to early diagnosis and treatment? Is it one of those diseases that can be avoided if detected early?
Yes, it's absolutely detectable in early stages. First of all, we have to be aware of the risk factors for PAD. If you have a patient who is around 60, 65 years old, who smokes or ever smoked, who has high cholesterol, high blood pressure, diabetes, you have to be on the look for those. And there's criteria for screening, meaning that a patient who's completely asymptomatic should be sent to screening if any of those risk factors is present. So the first test in a patient who's completely normal, who can walk and bike and run without any problems, if you share those risk factors, there's something very, very simple called an ABI. It's basically pressure measuring your ankle, the A, divided by the pressure measuring your arm, the B. It should be equal if there's no blockages. The heart should be sending the same amount of blood to your arm than to your legs.
Another diagnostic tool used is ultrasound, a technology that helps visualize blood flow within the artery.
Those waveforms that are being produced, that's the blood actually traveling through with every heartbeat. So you can see there's actually a very fast upstroke of blood going down, and when the heart relaxes, the blood kind of goes down a little bit and forward, and you have one cycle every heartbeat.
This healthy blood flow found higher up in the leg is contrasted with a weaker blood flow found down in the feet. Large, sharp waveforms are replaced with small, rounded ones.
In between this point and the foot, there's somewhere a blockage. So he's giving me an idea that his blockage is not really behind his belly button. His blockage is somewhere below the knee. And that gives you an idea what to expect, the length of the procedure I'm going to do, and the materials I'm going to use, balloons versus stents, and so forth.
Assessing the degree of blockage is what presents one of the most difficult aspects of treating these patients. The patients that do make it to angiogram or arteriogram, and that is a procedure by which we actually put a needle into the artery directly and put radio-opaque contrast or dye into the arterial system and take pictures with external fluoroscopy or radiography, is the most traditional method of not just identifying the true extent of disease, but also the method of treatment. That test in and of itself is not perfect either. It's a two-dimensional imaging method, and very frequently you will have very severe disease that if you do not rotate the plane of transmission of the X-ray, you will not pick up on the true severity of any given lesion. We have in our lab here three-dimensional methods of assessing the internal architecture, and that's in the form of an intravascular ultrasound. So slightly different than external ultrasound or duplex, that assesses the outside of the artery and measures velocities inside of the artery. We have an intravascular ultrasound that is placed directly into the artery and gives you a true three-dimensional picture of the interior of the artery. And that is likely the most accurate method we have today of assessing the degree of calcification or occlusive disease.
Historically, PAD has been treated by surgically bypassing the diseased area of artery. The procedure has proven effective, but is invasive, usually requiring large incisions and longer hospital stays. With the advent of catheter-based treatments in the late 1980s, devices and techniques evolved as an alternative method to treat patients in a less invasive way. Balloons were used to open arteries, stents assisted in keeping them open, and devices like lasers and atherectomies physically began removing plaque from the artery. Since then, devices have been refined and techniques mastered, giving patients new options, especially those too sick or old, or those whose blocked vessels are too small to bypass.
We're right here where, quote unquote, a little bit of the magic happens.
Okay.
This is our brand new endovascular suite here at TMC. And actually, we're in one of two rooms that are state of the art.
So what makes this endovascular suite special? You said it's all the latest gadgetry. Point out some of the really cool stuff.
Okay, first of all, the dimensions of the room, if you see, it's a fairly large room which allows adequate movement from side to side. And most of the people that work here, we have a vascular dedicated group of specialists that come in from the techs, from the nurses. They need to have space to move. Some of the devices tend to be bulky, so the space is pretty good. This is what we call a hybrid room. It's an integration of a normal OR with normal capabilities of any open surgery, but with the ability to give an X-ray in the live time. And so this, what we have here, this is basically an Angiocath machine. It's a fluoroscopy machine that's basically embedded, that comes from the roof and mounted on the ceiling. It allows it to be freely moved in whatever angle or position you need it to basically reach anything from the top of the head all the way down to a toe. So it allows us to basically treat a patient and look at any specific part we need in the patient.
So it moves and the table doesn't, or they both?
They actually both move. Tables will slide with very small movements of joysticks, as you can see in the panel here. This allows us to basically command the whole center. This is like the keyboard or the mouse, you can call it, in a computer. The little gadgets allow the table to move, and that would allow us to basically move back and forth and basically image whatever we need in a patient. And also the C-arm, which you'll see right now, that will move also left and right to allow us to move, or you could actually rotate it and give angles as you need in whatever case you're trying to see. So again, if you need to look at the right side of the neck, you twist it and you move the table, and that allows the surgeon to very comfortably find the image he needs.
So the vertical movement on the C-arm is by lifting the table as opposed to it dropping, or
you can do both. You can basically move the whole thing up and down, and you can also, if you want, you could actually move the table up, so it gives you freedom in any way, shape or form you can move this, and allows a lot of liberty when you're operating.
Okay, John, we're ready for your case. Any last questions that you have for us?
No, everything's been pretty well explained.
So this is going to take us about an hour.
Okay.
You're going to be kind of sedated, not completely out, but sedated, so you won't feel any pain, and in an hour, hopefully your circulation will be better. Okay?
Okay, I hope so.
Sounds good. I'll see you
Okay.
inside the room.
So, Jim, here, one of the key features when we're doing peripheral work or anything that's minimally invasive is you want to minimize your complications of everything. And so one of the first things that comes to mind when you say minimizing complications is access site.
Okay.
So your access site can basically make it or break it for you. And so you could do a beautiful intervention and do a lot of good for a patient, but if you have complications with your access site, then you can get in real trouble. So part of what we like to do is we try to do it ultrasound guided. And so that allows you to actually stick the artery that you have to stick in the place that you want to stick it. Everybody's different, and so the groin is the access site, but the groin 5 centimeters up or 5 centimeters down is completely different.
A typical access site for treatment of the legs is usually in the groin through the femoral artery. Most physicians use a contralateral retrograde approach, where wires and catheters are pushed up into the aorta and back down the femoral artery on the other side. This is typically the easiest approach and provides the best option for management of the access site. A second approach is called an antegrade approach, where the femoral artery is accessed and the wires and catheters are pushed directly down into the leg. This approach can be cumbersome and more difficult to close post-operatively in certain cases.
So why, when the problem is with the foot, can't they access it with a catheter closer instead of having to come through the femoral artery and all the way down?
Well, that's a fairly provocative question.
Sorry.
Because, no, in a good way.
Oh,
because we're actually, as you know, the technology has progressed, we've gotten to the point that now we have devices that are so small that you could actually access the foot itself.
Yeah. So what's all the hardware? Has he had some operation?
Yes, Mr. Lahari, unfortunately, being a frequent flyer and had some lower back surgery as well as some cardiac surgery in the past.
The question of access proves to be an appropriate one, as the team of physicians struggle to maneuver wires and catheters down to the treatment site.
At the end of the day, the technique of endovascular therapy is if you can maneuver or navigate that wire where you want it to go, the procedure itself is easy. The idea is it's got to go all the way down to the knee, so you will see that they will eventually start maneuvering. They're always a little angled, and that allows you to take quick turns. You want to go into a right vessel, you take a turn to the right. You want to go to the left vessel, you twist the wire, go to the left.
It's not gonna work.
Why don't you just do an antegrade puncture? You want to do antegrade puncture and then switch it up from above?
Could do that.
An antegrade approach is tried, but eventually proves futile. The wires simply will not traverse down through the tortuous anatomy. The team must move on to their final option.
While you work on that, let me just scrub and start trying to poke that foot. You okay with that?
Yeah.
Okay. I'm going to scrub. We need to prep that foot.
If they cannot gain access with a pedal approach, which is through the foot, John will need to come back for a bypass another day. While John's procedure is proving to be complex, there is another population of patients who are being treated in a new way. While not always the case, physicians are finding that early detection oftentimes can translate into more convenient outpatient therapy options.
In the past few years, across the country, many offices have been opening up that offer arterial reconstruction. It was previously felt that the office could not provide sufficient access to acuity of care or bailout medical necessity or techniques. It's been well shown in multiple publications that these can now be safely performed in physician offices
we still have a lot to do, but as we start finding some of those patients at a mild stage, mild to moderate stage, before they become fairly complicated and complex disease to treat, if we tackle that subset of patients, we could actually have them benefit from a standard of care that is not only inside the hospital.
Patient William Wallace has suffered from PAD for years, and the specifics of his case qualify him for one of these new in-office procedures. If all goes well, he will be in and out of surgery in just a few short hours.
I've had circulation issues with the legs ever since I'm able to remember, okay? At rest, pain, blood clots. Feels like a toothache, only more of an area, all of the foot.
That guy.
What guy?
This guy?
He tattooed my
All right.
leg.
I marked his leg. We're good to go. Mr. Wallace, do you have any questions?
Hey, I like the room.
Stay away from the blue.
And then if you can,
Scooch down in the bed a little bit. Okay. That's pretty good.
So Miguel, the procedure we did at the hospital yesterday versus the one we're doing today in the office setting, anything different you have to do in terms of preparation, precautions?
You know, basically, the big difference that you're going to have is in patient selection. That's where it's going to be key, is knowing what you can do in what setting for what subtype of patients.
Okay.
Because understanding there's a great array from people that might be relatively healthy to people that have a lot of problems. And so you grab the subset of people that you know could be dealt in an easy manner and can be dealt in an ambulatory manner and actually allow them to have that in the comfort of an office.
Okay.
Technically speaking, same thing, just a little smaller.
We're about ready to access the blood vessel.
Access this time goes smoothly. Using an antegrade approach because of compromised anatomy up in the aorta, Dr. Pakinowski quickly traverses the wire to the point of the blockage behind the knee.
So we're seeing...
And we feed the wire in, and
there we go.
of course it's going down the superficial femoral artery right now, and that's what we want. That artery extends as the popliteal artery, and that just changes names as it gets to the knee. We'll show you that in a second. And that's where Mr. Wallace had his prior intervention. He had a angioplasty and stent procedure performed some time ago and has experienced scarring, healing, or result of inflammation within the stent, which is a very common finding. What you're seeing is we're just still getting access, which means placing a sheath into the artery. And after that's in, we'll shoot a dye study here and take a look at what Mr. Wallace has, which is, so you can see on that image, your stent. Keep it coming in, Eric, a little more. We're going right to it.
With the vessel now visualized, the wire is advanced across the abnormal section so that tools like balloons, stents, and atherectomy devices can be delivered to the diseased region.
So you can see there that the wire's passed now through the occluded segment. It holds up there, which we expect because the narrowing, as you saw or didn't see on the arteriogram, is too severe to allow even the 035 catheter to be admitted.
Is the occlusion right under the end of the wire right now?
It is within the previously placed stent. So if you look at the knee joint,
Yep.
there's a metallic tube,
Right.
and that is the prior stent that we put in.
So John, maybe you can mag up and give us a nice angio now.
Yeah, I'm going to. That's what I'm working on.
So what's happened here is part of that inflammation we'll be talking about, which is a big demise of endovascular therapy, is unfortunately our results don't last forever.
Right.
Because actually the machines itself and the devices that we put can generate some inflammation, and down the line they could tend to occlude or re-occlude. And so right now what you're seeing is that a good result that was done years ago has now basically occluded the distal part. So if you see how nice and straight that proximal part is, and then it just basically becomes a
Peters out.
medusa of little arteries, and there's not a nice direct inline flow.
So the popliteal, is it one of the two on the left that come out at the bottom of the circle?
No, actually, those are all collaterals. You're really
Ah.
not seeing the end of it on that specific image. The popliteal is that little segment above.
Mm-hmm.
Then it just occludes right there, and then all of that little medusa, and then you're going to see a reconstitution in that next take that John is going to do without zoom, where you're going to see where it reconstitutes distally.
Take the balloon next, please. So we're going to load on the angioplasty balloon. It's a balloon used to dilate.
Let's start with the first device we're going to be using, and this is what we call the old balloon angioplasty. And why do we call it old? Because it's been done for about 40 or 50 years.
Wow.
We've been using this same technology, and up to today, it still gives good results when you use it adequately. So it's basically a balloon that we will maneuver into an occlusion or an obstruction, and the idea is that we're going to modulate the inside of that artery to try to stretch it open again. And so if there's a plaque, we're not going to take the plaque away. We're basically opening the plaque, fracturing a little bit, and basically inflating the balloon. It comes in different sizes and different lengths and different widths, and this is one of them. I just put a syringe, and I'm going to inflate what we would normally do with contrast and saline inside the body. And so as you do that, what starts happening is that little balloon starts inflating, and it starts basically opening up inside of the artery, basically pushing everything away. You want to give it a try?
Yeah, I see it
Sure.
already.
You can deflate, pull back,
Okay.
and you're going to deflate that. I'm going to do it now against my hand. Maybe sometimes it looks a little bit better because
You ready,
you want
Doc?
do
go.
the angioplasty. Nice work.
Okay,
I think you could be a vascular surgeon, Jim.
So is that occlusion that occurs after the stent's placed because of scar tissue generated, or is it because the stent itself is collapsed or fractured or narrowed?
No, it's just because there's ingrowth of cells
Mm-hmm.
called intimal hyperplasia. That's the scientific name,
Okay.
and that's what you're seeing. So right now on the screen, there's two dots.
Mm-hmm.
Those dots represent the beginning and the end of a balloon.
Mm-hmm.
And so the first thing that he's going to do right now, he's going to try to inflate that balloon to try to create a little bit more space for a potential machine that we're going to use to try to clean out some of that ingrowth scar tissue that has developed over time.
What you're seeing is that the balloon won't completely inflate due to the degree of blockage. So you see a little inflation down below. There is dye, and up proximal, that segment in between is not inflated at all. That's because of the scar tissue that's preventing the balloon, and we're at 10 atmospheres of pressure right now. So we're going to go to a slightly higher inflation pressure as we prepare to admit the atherectomy device, which we're going to open up shortly here. And we're going to remove some of that scar tissue directly. Go ahead and take it to 12. The way we create injury becomes very important. And it seems that people that have a slow, sustained inflation to lower peak pressures actually sustain less histologic damage to the tissue, and therefore less healing. And when the healing, so to speak, is less vigorous, there's less scarring. And less scarring means less failure or prolonged patency or lifespan of the device, right?
Yep.
You can see now that as we wait,
Yeah, it's filling up a
the
bit.
balloon now is continuing to inflate, and that
Yeah.
says consistent force is exerted on the stenotic segment. We're now left with one residual segment of stenosis
Yep.
that's right below the knee joint, but the rest of it's inflated, and you
Yep.
can see that there. So we're reintroducing a catheter here. The purpose of this reintroduction is we are next going to put in a device, a filter. It's called a filter wire. That will catch any plaque that would be dislodged and go downstream while we're working.
So envision you have a big plaque, and you're trying to modulate it. You're fracturing, you're opening, you're scratching the insides of the artery. Some of those small debris can actually break off and what we call embolize, meaning it would go downstream and occlude an important vessel. You basically maneuver it downstream of your procedure, and then deploy it, leaving it there, and then you sort of come back and work on the artery. Anything that breaks off is going to be caught downstream by that filter.
How do you load everything on, I'm assuming, the same catheter? You can't get two catheters side by side in the artery, right?
Right. What you would do is that instead of having a wire basically navigate through the lesion, you would navigate first with a filter, and it's the wire that's adapted into the filter, the one that we use to advance devices over. So the wire is going to be your working rail, the filter wire. Because you can say, well, how can you move that through an occlusion? Well, this actually comes on the inside, and so it's actually constrained into a small catheter. So at this point, you're going to start the procedure like this. You navigate through the arteries, you find where you want to place it, and at that point is, and I'm going to ask you to put a little finger here, is you're going to deploy your filter, and that slowly comes out and immediately opposes the wall of the artery, and now you're ready to do the procedure. Because now you pull your green catheter out, and now you move your balloons or your stents or whatever you're using over this wire. It's going to be your working rail.
So it's not the catheter that stays, it's the wire.
Right. You pull the catheter out, and then the wire is going to be basically your rail to push anything else in and out. And then at the end, once you're done, you got to come back, retrieve it back into the sheath, pull all the debris that you catched into this catheter, and now you pull the catheter out of the body, and you're done.
Sweet.
Pretty cool, huh?
Very cool.
We're going to go ahead and get that introduced, and you'll be able to see that on the screen here in a minute. So what you can see here, what we fed down into place, it appears to be a horseshoe that's inverted at the bottom of your screen. That's actually the filter wire. The filter portion of that netting you can't see on x-ray, but it's present below that horseshoe. That horseshoe opening lets us know that the filter has good wall apposition within the artery, and we've tried to pick a device that matches the size of the blood vessel which you place it in. So again, that would be to catch any downstream plaque, blockage, or scar that would dislodge while we're trying to remove it. And I'm ready for the atherectomy device when you guys are ready.
This is basically like our endovascular Gillette. It basically cuts into the plaque and debulks. When we're talking about balloons and when we're talking about stents and all of these other things, we're leaving everything inside. We're just making a bigger hole for the blood to flow. When I'm talking about debulking, what I want to do is I want to shave the plaque and try to grab pieces of that plaque and take them out of the body and create a better hole. And there is adequate data out there that the results tend to be very good also when you do an atherectomy. This is an atherectomy device, which means athero coming from plaque, plaque removal, atherectomy. Now the cutter's out.
Would I be able to feel on my finger?
Yep. And cut it.
Oh,
You'll
yeah.
cut yourself.
No.
It does.
Doesn't it ever cut the inside of the arterial wall?
Of course.
No,
You got to know what you're doing. So as the cutter basically exposes, imagine that our bed is the wall of the artery. So now I basically move forward, and the cutter is basically cutting and shaving that, and it just basically stores it all the way along the anterior chamber, meaning this space here is going to be basically grabbing all of the plaque that you shave through the cutter. And you will see when we do a case where actually we can take all that plaque and show you guys.
So here now we're going to go ahead and put in the device that Dr. Montero showed you. It's just the atherectomy device we're placing through the working sheath. And again, the purpose of these sheaths is to protect the artery from all of these. You'll see us on this table and going in and out with different devices as we change, put catheters in, put plaque removal systems in. Whether they be lasers, atherectomy catheters, balloons, or stents, that causes trauma to the blood vessel. So these sheaths protect the area where we initially poked with a needle and put a wire in to cannulate and gain entry inside the blood vessel. So it protects. Here comes the device.
Yeah.
And we're going to start up there, and we'll start working away if Dr. Montero wants to explain what we're doing.
As you're going to see, John, he's going to activate, as he passes forward on the device, he's going to turn it on, activating the motor and the vibrational system, and now he's ready to cut away. So then he's just going to advance in slow passes down the side of the inside of the stent in order to grab some of that inflammatory scar tissue.
So we're going to go ahead and get started here. There we go. Go ahead and turn it on.
So that noise is the cutter, the atherectomy device?
Exactly. As you advance the on-off switch, which you can see in, then that actually triggers the activational system that helps the cutter basically first expose itself, and number two, vibrate adequately.
We rotate the device. We make initially 4 passes in 4 quadrants. Go ahead, turn it on. And then we'll remove the device and remove the plaque or scar that's in it. You can see the patient is moving a little. You just take your time and go slow. And
from the fluoroscopy there, can you see if any plaque is being caught by the filter or by the atherectomy device?
You won't see it. Plaque is invisible. If it's scar tissue, normally it's not calcified. It's just more like fibrous sort of jelly thing. And so that you're not going to see it, but you will certainly see it at the end once we retract the device, and we'll certainly make a point to show you guys how that plaque is basically being stored into the device, into the distal tip of the device.
Off. Rotate a little there.
He's turning the feed device there. Is he trying to get different sides of the artery, clean it out?
Yes, and this is why we call this a directional atherectomy device.
Okay.
Meaning you have to actually, it basically flexes in a way that it gets the little cutter exposed into the artery wall, but then it takes a lot of maneuvering and technique for you as the operator to actually twist it so that your cuts are along the side that you want to cut. And so, one of the techniques that you utilize is that you actually imagine in your brain a clock. And so you do a pass at 12, then you twist the device 45 degrees, and you do another pass at 3, then you twist the device, do another pass at 6, then you twist and do another pass at 9, and you can certainly keep that going to the point that you actually, in your mind, in a 3-dimensional construction in your mind, atherectomizing the whole circumference of the vessel you're treating.
So we're going to go ahead and remove it now, and remove the plaque.
Do you have any feel about how much plaque's there, how hard it is?
Yes, sir. You can tell as you move through a plaque that you just have to slow down and allow the machine to do its job, which means to give it enough time to take its time and cut through the calcified and very firm, tenacious plaque and push it out. Let me have the pickup and I'll help you here. So this is what you can see, guys. Do you see that stuff coming out?
Yeah. Oh, yeah.
This right here is the stuff that we're removing. Firm, rubbery, scar appearing type stuff. Go ahead and push. Yeah. So we'll lay that out for you, but basically it's tubes of scar that are delivered into the catheter, and if we elongated it, it would be the length of the segment we treated, which is about 6 inches, as Jim says.
Dr. Pakinowski performs a few more runs with the atherectomy device, removing additional scar tissue. Upon completion, the filter wire is withdrawn.
Okay, so we're going to go ahead and take out the filter wire now. And as you can see there, and there is some debris in the filter wire. That helped us catch some of the otherwise what would be embolic particles are present in the distal part of the filter wire. You can see here that there's some of that plaque and atheroma that was captured by the filter wire and therefore prevented from going down the leg and creating potentially a situation that has consequences.
So you talked about the scar tissue that had formed as a result of the stent operation last time. At the end of this operation, will the same thing happen again?
So it's a great question. So the answer is yes. For example, if you had a scar on your skin and I made an incision right down the middle of it, would you heal that?
Yeah, but you'd have another
that's
scar.
Right. And it's the very same mechanism that we heal again, so to speak. It's when you re-intervene on someone who has a failed intervention, if you're in the exact target lesion, so to speak, and you're intervening in the exact same location, the results are better the second time in terms of durability than they are the first time.
Is there any drug that you could administer to reduce the amount of scarring or try to defeat that a bit?
Yes, and as a matter of fact, most of them are not past the FDA right now, but that's the next generation of interventional aids, and that is drug-eluting. So as you can see on that image, there's still a large amount of scar and debris present within the stent, and this is a very, very characteristic appearance of of the results we see after atherectomy. You see what appears to be a worse result, but if you recall, there was no flow at all initially in this artery, and now we've restored flow. So of course there's going to be some defects where we created the trauma and made linear incisions along the inside of that scar. And that's what you see here on the screen. And you can see just the irregular appearance and non-uniform opacification or blackness that is the inside delineation of the blood vessel there. And we're going to do some maneuvers here to kind of to tack that. And by that I mean we're going to place a stent within this stent to tack that remaining flap distally. And this will preserve his outflow.
So once you open up a vessel, we figured out many years ago that some of those vessels are so calcified or so full of plaque that actually you can't open them only with a balloon. And that's when the concept of formulating a metallic device that will keep it open just basically by its strength, and that would allow the patency rate, which basically in layman's terms is how long is this procedure going to remain open. Okay. Then you can optimize it by putting a metal scaffold that allows that artery to open, and that's what we call stents.
Okay.
And so a stent, they're made to be very flexible, so you can put them in different parts of the body, and you know that your leg is going to be flexing, and so it allows the movement of the stent to basically conform to the artery. Okay. Now you say, well, this seems like a bulky thing. How would you put this into an artery? Well, it actually comes constrained in a catheter like this one. So this stent comes inside a catheter like this one.
That fits inside it?
Mm-hmm.
Wow.
And so they're made so that we could actually pass a lesion or an obstruction, and once we know we're exactly where we are, which we can confirm with our imaging, then we open the device. So I'm going to have you just put a little finger here.
Okay.
Imagine there's an artery here, and this is already in the specific place. Mm-hmm. And so what we do as we basically pull the levers of the device, that allows the stent to basically come out. And I'm going to do this real slowly so that you can envision how it is that we actually pop. And that's a little small one. That's a baby stent compared to this other one. But you can see certainly the differences. That's just a shorter stent, but the same properties. It's a self-expanding stent, and that would oppose to the vessel's wall and the therapy be completed.
So contained within this catheter, which appears uniform and nothing visible, is a stent exactly like you see on the screen. It's the same company, same device, slightly smaller size, but there is a stent contained which will deliver with the use of the handle and a ratchet type mechanism, which you'll see in a minute here.
So does everybody create scar tissue in a uniform manner, or some people less than others?
When you cut your skin, once again, making that parallel, some people develop what's called a keloid scar. So some people have a reactive skin, and others, you can barely tell the patient had a cut. It's the same inside the arteries. Some people, for unknown reasons, they react much more traumatically than others. So in those lines, we haven't identified any risk factors as to who's more inflammatory prone than other people. What is true is that people have clear differences. You put stents, and 2 months after, they are completely re-stenosed. And other people, 5 years after the stents, are pristine with nothing inside. So there's still a lot to learn.
We're deploying the stent here, as you see.
So you're seeing John is liberating that stent right now. He's deploying. As you push forward and backwards, it's basically allowing that to release the stent. And so, as you see on the screen right now, it's depicting beautifully as that stent starts basically opening up. Remember, these are metal alloys that are made of nickel and titanium, and they're thermosensitive, meaning that as soon as they hit that bloodstream and the temperature is warm in there, immediately they're going to come out of the catheter and basically expand into the form that they have. So that was a great deployment. They landed that stent distally into that issue and a little bit into the old stent, so they're covering also at the same time the old stent. So now, in other words, you have 2 metal stents, one overlying the other one, and then a little piece of the second one that was deployed covering the unhealthy vessel that was uncovered before.
Dr. Pakinowski balloons the vessel an additional time to gain a little more expansion of the stent. Once done, all that is left is a final dye study to measure the procedure's success.
Can you come off mag now, Eric, and we'll get a shot here and take a look at what we got.
Of your
So,
Holy, beautiful. So as you can see, Jim, in that image as it's flowing down, you have a complete, beautiful, circular, adequately filling artery. The collaterals have simmered down, and there's adequate blood flow, and you can see actually it divides into those two nice vessels below the knee. And so this is what we would call a great technical and angiographical success.
It appears William's treatment has gone well, a straightforward case that should alleviate his leg pain, and more importantly, keep the possibility of amputation at bay. The team is hoping for similar results with John Lowry. When we last left them, the physicians had been struggling to gain access and deliver the necessary wires to the diseased region below the knee. They're now turning to a new approach called pedal access, where they will try to enter directly through the foot just below the blocked anatomy.
So this case going in did not look like too difficult a case. Is this typical? What percent of the times do you have the lesions and you can't make the reentry?
It's very infrequent, actually, to not be able to obtain antegrade traversal and reentry. I would say 95% of our cases are done with an antegrade method. It's only maybe a 5% failure rate with which we resort to this technique, and I don't believe we've had any failures with retrograde passage yet. They're pretty much there, so we're across the first.
At last, success.
Woo-hoo! All right.
Patience has paid off as the wire is now across the lesion. Since the arteries being treated are much smaller than those found higher up the leg, an atherectomy is not an option. John is treated with a balloon and the circulation is restored to the foot.
Beautiful.
And
So
that's
as
the
you see,
AT?
That's the AT. Now recover. You remember how it had two occlusions?
Oh yeah,
Now it's completely open and,
and a lot wider too.
It's wider, it's open, and now
Darker.
as you see the distal takes, look at the last runs as it moves down. You're seeing now the arteries that go to the foot and to the toe are now widely patent.
Yeah.
So
The operation was a success.
absolutely.
We went over the details with your wife last night when you were still sleeping, but I gotta tell you, it was quite a difficult case. You had a fairly blocked artery, as Jim can witness as well. From the knee down to your foot, it was completely blocked.
While these less invasive treatments for leg blockages do have their risks, like any surgery, they appear better than the alternative, amputation.
So an amputation's a pretty big step. The statistics say that something like a person has an amputation, their life expectancy has been reduced by 50%. That's a big chunk of life to give up there. And yet, we also see that about 40 to 50% of patients who have an amputation don't even get any kind of screening. Where's the ball being dropped there?
Not every amputation is caused by PAD.
Right.
There's amputations that, for instance, are done when you get in a car accident.
Sure.
And your foot and your leg gets mangled, and basically the bone is destroyed, the nerves are destroyed, and everything else. The amputee, if he has been properly treated, it represents a much more severe end of the spectrum of PAD. If that patient reached an amputation stage treated by a proficient and skilled surgeon, then it's a marker of much more severe disease and bigger plaque buildup that person who had her blood flow restored. And so that may mean that the heart disease is also very severe as opposed to that person in the less severe end of the spectrum. Now, that being said, I live this on a daily basis where people are referred from communities outside the city where I work, and yet they've been dealing with these problems for months or years, and nobody look at the arteries when it's so simple when they come and just look at the arteries and know that there's a big blockage and you can fix those problems. So education is paramount. Education for patients and actually for physicians.
Failure to recognize or be aware of the symptoms is likely the most common reason why it's underdiagnosed. Along with that is the location of the arterial system affected. You know, as we mentioned earlier, the deep location of the blood vessels make physical examination difficult, if not impossible.
So what can physicians do to become more aware of the testing methods, and what can patients do to become more aware, more educated?
I think communication is the biggest thing, and at the end of the day, the truth is that appropriate referral to someone who treats vascular disease or wounds There's been an expansion of the wound care centers in this country recently, and that certainly has resulted in an increased recognition and a earlier treatment being offered to these patients.
So worst case scenario, patient goes into their PCP, referred to a specialist, the specialist recommends amputation. What should the patient do?
You put me in an awkward position for that question. Jim.
Okay, why is that?
Well, it's hard. Let me say how I can be politically correct when I say this. I think there's different points of view in life, and I think there's people who have the skill set to treat a more complex set of patients. And I'll let you derive your own conclusions, but I can tell you I've had a multiple array of patients that have at some point interacted with specialists of different subspecialties, not specifically vascular, that have suggested an amputation. And when they roll into our office, we tend to think that it's different, and our outcomes have in general been good. So with that, I don't mean to say that everybody that is told that they have or need an amputation should get one or should not get one. I'm saying that I would expect the right specialist with the right skill set and knowledge set to tell you what you need.
And so at the minimum though, wouldn't a patient be advised to seek a second opinion if amputation was suggested as the only option?
I think that's a viable comment. I think that people should at least be empowered with the knowledge to know that if you're not getting an angiogram, why is this? Did I get an ABI? Did I get a duplex? Or am I just getting an unfair, simple judgment day sort of decision without really the adequate information? So I think it takes a lot. I don't want to say people don't get to that, and I myself have sometimes given amputations to patients, unfortunately, when it gets to that point. But it really is the last resort, in our practice at least.
A last resort, something that patient Donna Riesco learned the hard way. Ignoring her symptoms in the past led her to losing a toe. Hopefully, by taking action now, she can avoid any future amputations.
You know, I guess I was one person that didn't like to go into the doctors, and I did ignore them. Don't ignore them. It's just, you would, if maybe I look at it this way, maybe if I had gone in sooner and hadn't ignored it as long as I did, I'd still have my big toe. It cost me my toe.
Donna is here today to minimize the damage brought on by PAD. The procedure will allow her not only to keep her leg and her foot, but also keep the hope alive of years of healthy activity.
It's a pretty decent result. Pretty happy with that. I think that will get her wound on her foot healed, get her out of what we call limb threat.
A week after surgery, all three of our patients are doing well.
Good morning, John. How are you?
I'm doing fine.
How are things going?
Very good.
Any problems?
John's ulcers are beginning to heal.
It's been 10 days, no rough time, no problems, been feeling fine. Back to most normal activity now.
William's leg pain is decreasing.
The pain is 50% less than before the surgery, so it's got a ways to go yet, but I'm expecting it to get better.
And Donna is seeing her endurance slowly return.
How are you feeling today?
Very good. My goal is to hit 30 minutes on the treadmill daily, so. And I really think the exercise helps my health. I don't think it's just a given. It's not a freebie. They go in and they clean everything out and everything's okay. I got to work at it too. I got to put my part into it.
The keys to stopping PAD are prevention and early detection. While you can't control your age or family history, you can quit smoking, control your diabetes, and take steps toward living a healthier life through exercise and a nutritious, well-balanced diet.
I guess the message that I would send is don't ignore your body. Don't ignore symptoms. You know, you may not know what's wrong, but you know something's wrong. And I ignored it for a really long time. and I probably would have maybe had less medical procedures if I hadn't ignored it than I did.
As you have seen, there are options when facing a diagnosis of peripheral artery disease. Which one is right for you is something you should discuss with your family, your doctor, and perhaps even seek out a second opinion. The stakes are high, and you owe it to yourself to know what your options are and which solution is right for you.
If you'd like to learn more about PAD or see bonus materials from this episode, please visit us online.
The latest procedure, endovascular leg therapies, is made possible by contributions from the Friends of Eight, members of 8 Arizona PBS who give additional gifts to support original programs.